Hey everyone, thank you so much for joining us. I'm Rebecca Segraves,
And I'm Jenna Segraves.
and we are the co-founders of Enhanced Recovery After Delivery. And we are so excited just to have a Q&A and answer a lot of questions that we just get in general about offering occupational therapy, physical therapy early after birth, typically within the first 7 days, where we typically don't see those services being offered. Am I right, Jenna?
Yes.
Yeah. And so we used to say, we're filling a 0 to 6 week gap to cover more inpatient postpartum services that might be offered in some hospitals after birth. And then also just the whole period that usually patients aren't referred at all to OT or PT once they return home, which is within the first 6 weeks until they're cleared by their OB/GYN. But now we've really been focusing and doubling down on the first 7 days. And so those are the first 7 days where that person, yes, they could have been treated in the hospital. But a lot of times we have therapists, about 50% of our therapists that we're training are actually seeing those patients either virtually or in the home within that first week as well. So we've really are capturing still that critical time period after birth where two major events happen in terms of percentage, the most, that's postpartum hemorrhage up to the first 7 days, and then also infection which unfortunately can manifest even after that person returns home, where they're maybe doing a lot more activity. They may tear on the inside. There's a huge wound where the uterus is still healing from when the placenta was birthed. That is not able to accommodate a lot of the activity that some of our moms are exposed to, whether they have limited family support, if they're single parents, if they have a baby in the NICU, and now they have to get transportation back to the hospital and walk, not be wheeled down in a wheelchair. They're just doing more activity than what's normal. We're looking now at a period that needs to accommodate all those different lifestyles. And so we really wanted to train therapists to accommodate all of those different cultures, all of those different lifestyles, all those different circumstances surrounding the mom and her situation, and not kind of be on the side of where history has really created a disadvantage for this population by creating a 6 week gap that didn't need to be there, especially from us. From a rehab standpoint of not providing our services early enough as we would after an ACL repair or a shoulder replacement or a knee replacement, we wanted to make rehab services accessible to those patients after any birth type, but especially after the most common surgery performed in the world, major surgery, which is,
A cesarean section.
you believe that? Like the most common major surgery performed in the world. So I actually wanted to kick off this Q&A, which I'm really hoping it'll go out to Pelvic Health Network members later, but it's a Q&A that is in the form of a presentation where we're hoping to answer a lot of the common questions that we receive. But then as if anyone feels comfortable who might be joining us live later on, feel free to ask questions that we didn't quite cover. But it's a very short presentation and kind of gives you the bare bones of really how these services came to be. How did OT and PT really be more now a priority after birth? And I'm really excited to just share our journey because that's often a question that we get, Jenna, is how did we get started? And you're so unique. I'm actually going to give you your own stage to just speak about this later on after we hear from Dr. Karen Fox at the end of this short presentation, because you are not a pelvic health therapist. Am I right about that?
You are correct. I am not. I'm a neurologic clinical specialist. So, I do not identify as a pelvic health therapist. That is true.
Yeah. All right. Well, we will definitely dive a little bit more in to your background, to my background, which probably makes a little bit more sense in this population. Um, and then kind of answer those common questions that we have not been able to get to since we've presented for MedBridge, since we presented for the acute care APTA section. And there were still always all these questions that were just like, we are not getting to these tonight. At least over 30 or 40 questions that we just did not get to with each of those presentations. So I'm going to try to answer as many as I can, but then jump into more of the live questions that we might get. So Jenna, you'll actually recognize this person right away, right? In your relationship with her. Yeah. Really kicked off right around the time that she called me. Now, this is Pamela Daniels, and a common question that we get is who's on the cover of our manual? And our manual is called the Acute Care Obstetrics Rehab Manual that we use to train uh, therapists, occupational and physical therapists. We have updated that manual now, Jenna, since 2022, I want to say. And we update it at least twice a year, just with any of the latest evidence, research, patient handouts. We're actually getting it translated into Spanish so that it can be more accessible to more people. But now with kind of her story, she's on the cover of that manual, and that's really where my idea even of getting this out to other hospitals other than the one that you and I were working with or in, that's where it really started to unfold with her story. Now, Pam and I, we grew up together. We were in diapers. So this is my best friend, um, family, and she was giving birth in September of 2020 alone in the hospital in New Jersey. And I remember actually getting a text from her about her cesarean section pain. And I didn't even know that she had given birth, let alone by C-section. And at that time, Jenna, you and I were treating in the same hospital
That's right.
women on the maternity unit, on the high-risk pregnancy floor.
Mhm.
And then, Jenna, you were also seeing some of the patients that we didn't get to, but also after hysterectomy. Is that right?
Yes. Yes, that's correct.
Yeah. And so when I received that text from Pam, I knew that at the height of the pandemic, this was COVID, September of 2020, she was in a hospital where she did have someone, she had her best friend also at that time who was with her for a few days while she was laboring. But then once she went to C-section, her best friend had been there for several days, night and day, had to leave, and the hospital had a rule that said you could not return if you were a visitor back to the hospital. So Pam essentially was alone in the hospital, had given birth by C-section, and I get a text and she's asking, "What do I do about this pain?" So here I am realizing my best friend just delivered. She's alone and she is recovering after a C-section, still within the hospital within the first 24, 48 hours that I get this text. And over the next 12 hours, I am busy calling the hospital, getting to the rehab department, and trying to convince the acute care therapist who's sitting on the order. Because at this time, Pam has to put me on speakerphone for everyone to speak to the OB nurse, to speak to the OBGYN who's in the room, who wants to know why is your family member friend on this phone pushing for you to have physical therapy? We don't offer physical therapy in the hospital. Why is this a big deal? Why can't you just get up like the rest of our patients do and just manage? And in my head, I knew Pam's situation. She was planning to take a taxi home. She had 14 steps or more just to her front door. There was no way around that. And she was planning to carry her newborn in the carrier up those steps after a major abdominal surgery. I don't think anyone who's a clinician would want that for their patient, a stranger, or even someone that they know and love. And I shouldn't even say even someone, especially someone that they
Mhm.
know and love. And so Pam became the story of how I was introduced with to remote healthcare for the first time. I had never helped someone recover remotely, like not being there one on one before that. So before virtual therapy was even top of mind, like it is for me now, I was helping Pam get and advocate for her to get the services that she needed because I knew I could do so much over the phone or so much over a FaceTime call, but I knew that she would probably get more out of a physical therapist or an occupational therapist being right in the room with her. So we walked her through that postpartum recovery. We walked her through a cesarean section infection recovery because she, had one even after all of that and really just walked her through a recovery in her first 4 weeks from day two, really, after C-section. So that's why we're so adamant that rehab therapy education programs for OT students, for PT students, introduce this population along with any other post-surgical population that students in the rehab profession are already going to learn about, but at least mention the most common major surgery in the world, which is cesarean section, at the student level to prepare students. We get a lot of questions from students, and that's something I want to be able to answer today. And then, Jenna, if you can, give your thoughts on that. What could students learn about this population that is entry level practice? And I think that you have some background on this.
Oh, yeah, absolutely. There's so much that students can learn that would be considered entry level. So if we're talking about cesarean section, I mean, that is a major abdominal surgery, and they know anatomy. They learn about other types of abdominal surgeries and best ways to mobilize someone immediately after something like an abdominal surgery. And so there's so much that they're already being exposed to the importance of vital signs and assessing those before, during, and after activity. These are all the same things that we would want to do with the same population because they also have that risk of having a postpartum hemorrhage, like you mentioned, or they could even develop postpartum preeclampsia as well. And these could be some of the early signs that someone is able to identify some of those diagnoses.
We get now, it's been at least the past two cohorts, more OT practitioners,
We have.
um, uh, OT, CODAs, and OT students who are doing their capstone. They're enrolling in enhanced recovery after delivery, the training. What would you say, even for their programs where OT isn't really as common as it's becoming in physical therapy and just pelvic health, maternal health, women's health in general? What would you say is really just food for thought for, some of those OT capstone directors who have reached out to us about like the interest that their students are having? How could they integrate this content into OT curriculum?
Oh, well, I think that if we're talking specifically about this topic,
Hmm.
so perinatal, postpartum care, I mean, this is now someone who has, a whole new role that they have to go through. They have new ADLs. They likely have new IADLs. They have to deal with what's the word? I'm not an OT, so I'm struggling with some of the OT specific language that they use. But this is now someone who maybe had an identity beforehand, and now they're trying to figure out how do I maintain that sense of identity as I move into this other identity, which may be a mother, right? In addition to some of the things they may have identified as beforehand, such as a runner or a swimmer or any of those other things that bring them joy and value in their life. And so you had mentioned something about sort of the pelvic health realm that I don't know if we necessarily need to go down that route for this call specifically. But I will just say that when it comes to bowel, bladder, and sexual function, all of those are considered ADLs as well. And so I don't think it's quite fair for us to, as physical therapists, to say this is only our area and OTs are not welcome here, when in fact it impacts multiple areas that affect this person's well-being as well as ADLs.
Right. And I love that you mentioned identity, their role, their identity it has changed. In my own practice, in that same vein, I was treating with an OT, in the hospital, in our hospital, where we were seeing women after birth, recovering within the first 24 to 48 hours. And I remember distinctly not knowing what else I could do, but just watching the OT take lead of the session with a mom who had lost her baby at 28 weeks. And, the baby had been in the room with her, but then was taken to the morgue. And she was not ambulating, getting up very much, but it was the OT that was engaging her in a standing activity of just folding the clothes that she had gotten during her high risk pregnancy stay for her baby. She very much, had already been collecting gifts, for a birth that she very much thought would end up in a newborn, a live baby.
Sure.
So when the OT took lead, I knew that this role was way bigger than me. And so you're right. I mean, I do, and we have heard of pushback from OTs in this not just pushback, Jenna, but just an under misunderstanding of what the role of PT is and what the role of OT is. I'm still being asked that
Absolutely.
question.
Yeah,
Um,
we do get asked that a lot. And I will say that so my background is primarily acute care. That's really where I have spent the majority of my clinical career practicing. And so I'm not going to lie, there is overlap between physical and occupational therapy in the acute care setting. We're both going to be looking at how someone performs bed mobility, transfers, their endurance, but there are nuances, there are differences between us. That's why we have different letters, credentials after our names. And so having a good solid understanding of what do I do, what can I bring to the table, what's within my scope of practice, but also having an idea of what other healthcare disciplines scope of practice is as well. And if you're a little muddy on it and you don't know for sure, ask. They will be more than willing to share, just like I would be more than willing to share what's within my scope of practice as a physical therapist.
totally agreed. Totally agreed. You and I were both at CSM this
Yes.
year.
Hmm.
And we actually were able to, be a part of this presentation, if you will. I want to say
Oh,
session
yeah. Yeah.
by Duke. And we're laughing, right? Because it's just funny. I graduated from the Women's Health Physical Therapy residency at Duke back in 2016. And at the end of 2020, you and I were writing our first commentary on this topic, acute care physical therapy in the hospital after C-section, and just writing about the experiences that we had treating this population so acutely. And I remember calling my residency director and just like telling her our idea. First of all, our paper was not accepted at that time. There was some pushback about
Hmm.
whether or not it should even be published in the physical therapy journal. Should it be published more in the women's health journal? And here I am pushing back saying, no, this is a major abdominal surgery. Any therapist can be trained to treat this population. They don't need to be a women's health therapist. You weren't a women's health therapist. You were in
I'm
acute care
still
and
not.
neuro, and you're still not.
I'm still not.
And I remember her laughing, right, on the phone, like
Yeah.
just laughing, like this will never take off. Like, PT in the hospital after birth, that's just not going to happen. I knew that she was a big proponent of early cancer intervention and had piloted and just started these programs, amazing programs after cancer surgery for patients to be treated early on. So, I mean, did it discourage me? I mean, I think that you have your own stories of worse where an OBGYN hung up on you. And I mean, that, definitely
Yeah,
probably hit a nerve. I mean, we both have had rejection on this issue,
absolutely.
right?
Yeah.
Like that's an understatement.
Yeah.
But I think it's also just a culture thing or just something, not just even me or you, it's just other people. Like we don't hear no, we hear something else. Not right now. We just hear something else. And I think that when we both sat in the audience and we heard Duke Health present, and they ended up calling me, not
Yeah.
even a year later, Jenna, they ended up calling me and wanting to consult, like, hey, we see that you published a paper. We see that there's some chatter about, offering physical therapy, occupational therapy in the hospital after birth. Let's talk a little bit more about that. And I remember doing two consultations with them in 2021 and 2022. And then this in 2025, they announced this. They through their presentation at CSM
Hmm.
in February of 2025. And I quote, and I'm quoting, kind of paraphrasing just kind of, what my residency director, Lisa Massa, presented on. She said at Duke, we average about 350 births a month, and the readmission rate is about seven a month. So, seven patients they're expecting to return to the hospital from some complication, infection, maybe hemorrhage, preeclampsia, something. The cost of readmission she was referring to is about five to $8,000 per person. So that's the cost to the hospital, how much money that's spending or the cost to the patient. So during the 18 months of our program period, we would have expected about 120 readmissions at about seven a month. Seven or eight is what they were averaging. The number of readmissions during the entire trial period, their trial period was an 18-month program that they were just trialing physical therapy in the hospital after birth and via telehealth. So they did a virtual component too, where they saw those patients or at least virtually cared for them within the first week. She's saying the number of readmissions during the entire trial period was six. So not 120, six.
Wow.
They roughly saved the health system over $500,000 in the first 18 months of the program, where we were still trying to figure out everything. And Jenna, do you remember what I wanted to do during their presentation?
Yes.
I wanted to like stand up and say, "Who's laughing now?" Like I just wanted
Yeah.
to pump the air. I mean, I seriously like not even I told you so moment. This was purely like or I was overjoyed, I should say, that they've really, I think, validated. I was waiting for
Yeah.
this for 4 years that they just validated as a major health system that is heavily resourced, more than where our therapists are coming from, usually, who take this training. Heavily resourced institution, saving that amount of money that completely changed the conversation for me.
Yeah, and I would completely agree with that, that this, what they did, just like you said, I mean, it's completely validating and a reason to jump for joy because everything we thought would happen and what we knew they now actually had the numbers to support it, the research to support it, which means we can now continue this momentum. And I think it's going to drive a lot more hospitals to start to make these changes as well, which means we're going to be helping more and more women after birth, which is really what the entire goal and point of enhanced recovery after delivery is.
Absolutely. And we're tracking how many hospitals, and we are not, we're far from accurate, right? Even on our website, Pelvic Health Network / hospitals. And I say we're far from accurate because honestly, our information is not even including some of these institutions we know out there are offering OT and PT services on the maternity unit, but at least we have some type of measure and we're trying to track the numbers. We're trying to get information from social media, from whoever is able to give that data, because it's just not published anywhere else. You cannot go as a consumer, as a patient, as a mom who's expecting to deliver in the hospital. You just can't find this information anywhere. Am I going to get OT or PT services? Am I going to get a rehab plan of care? Is my birth plan going to um, one, even be used, or is my team going to take it seriously? First of all, my birth plan, my preferences, but then is my birth plan going to have that recovery component? Will I be told how to actually recover that fits my lifestyle? If I was a runner, if I was a cyclist, whatever it is, will a recovery plan be, fit to me, customized for me? And you cannot get that information, at least in the United States, it's just not available. And that's something that we also started to do after we were consulting with hospitals like Duke, is we have to start to get like this roster, this directory of the hospitals that are at least providing these services so that we can later, knock, knock, knock and say, we'd like to really know over the past 5 years, what have been your outcomes from providing these services? And Duke was the first hospital, major hospital, to announce, and that's a question that we get in this Q&A. I wanted to like cover in detail how we started, who we've, now either partnered with, consulted with, what the outcomes have been from all of this. I really wanted to answer the major questions that people have. Can this save lives? Can this save money? What are you seeing out there? And all we can do is just relay the information that these hospitals are now sharing publicly, because we don't have access to all of this information. We're training therapists, but then we're not in their Epic systems, or their EMRs. And so I wanted to, one, share that because you and I both were there. But then I also wanted to share a story from a patient. And you'll recognize the person on the right? Dr. Ann
Oh,
Krogan.
absolutely. Yes.
Yeah, I mean, she was the first therapist that I knew of, period. When I saw her speak in Denver at CSM in 2020 to even announce that there was anything like this, that there was a field of acute care therapists that were providing physical therapy in the hospital after birth. I had never heard of those programs. Now, at the same time, I had just taken a job as an acute care therapist myself in a women's health hospital, but we were seeing patients after hysterectomy, prolapse repair, like very minimal on the maternity unit. But she had started a whole program where every patient after vaginal and C-section delivery were being offered physical therapy as just a standard of care in her hospital. And I
Hmm.
wanted to share a testimonial that backs up, that claim that offering rehab in the hospital saves lives as well as money, as we saw from Duke. And let's see if it'll play.
My postpartum experience was a lot more challenging than I had initially expected. I'm still seeing Anne for physical therapy from a pelvic floor, and we're at 10 months now. We're making progress, but I mean, so many women have no support at all. And I mean, I can't imagine doing this at all without the support system that we had. So I feel really lucky. I kept telling Dr. Beaupre, I was like, I haven't slept in like a week. That's the reason why I have this headache, I mean, it's a lot of work to care for a newborn. And I had, my husband was off and my mom was here. I had a pretty good support system at home. So I feel like Anne is really sensitive to like each individual patient's normal and not just the normal that's on the paper. And so I had pretty low blood pressure my entire pregnancy, and that was normal for me, not pregnant as well. And so my elevated was not necessarily, what elevated is on paper. So I think Anne viewing what is specific to each patient as normal was really critical.
So, Jenna, you know this story now, but most people don't. And we get this question a lot is, especially from like practicing clinicians and even the clinicians who have taken ERAD or not, or starting, services on the maternity unit, and their pushback and their main question to us that we've not been able to answer in depth in a lot of the presentations we given like through MedBridge or APTA acute care is like, well, if you get pushback or if you can't get buy-in from the OB care team, or they're not taking vital signs, or they don't think that that's necessary, it's just something along those lines. Like, well, what do you do? And I share that story a lot now with our trainees, but publicly, we don't talk about it enough, like what that story and how significant her story was. But in that case, Ann Krogan on the right, who we talked about, who helped start a program in her hospital that offered physical therapy services after vaginal and cesarean delivery. Well, she was an outpatient women's health therapist who did that. She had to go into the hospital, train the inpatient staff, get the program up and running. But meanwhile, she was on the outside creating a program that allowed her as a hospital-based employee to go out and do home visits, postpartum home visits within the first 3 days. In that particular case, that was a mom who was 3 days postpartum, where Anne took her vital signs and caught postpartum preeclampsia.
Yep.
Saved her life. The woman actually ended up being readmitted back to the hospital for 9 days,
Wow.
right? And it was all because Anne, was seeing signs and also just understanding just blood pressure. We know that it actually drops or should drop during pregnancy. And then
Yep.
even postpartum, we really shouldn't be seeing it climb. And so when her elevated was above her baseline, and immediately contacted the physicians, and it was a series of events, but eventually got the mom back into the hospital. So that's where my passion area is in now, is what could we do in the first 7 days, even when that mom is discharged, and what do we need to be training acute care, occupational and physical therapists, but even our home health, mobile therapists, virtual care therapists, outpatient therapists. We have 50% of our trainees in these programs that we do several times a year, who don't represent a hospital setting, who are treating outside of it. What do they need to know? And so I really wanted to share that story because that's a testament to Anne, who started this service. And now we were able to get that mom to give her testimonial as well. But then there's more, right?
I would say my
You and I have authored um, now several commentaries on this subject. And our most recent one is right in the middle, Maternal Health Disparities, that was published just last year, that really call out to our acute care colleagues, who may be differentiating care for this population as opposed to, someone after another abdominal surgery that you might see, which would be what, Jenna? What patients in the hospital have
Oh,
you personally treated?
after a gallbladder removal, so cholecystectomy or a colectomy, removal of part of the colon.
How about after hemorrhage? Have you ever treated any patient after a massive transfusion protocol?
Oh, all the time. Yeah.
Yeah.
Just generally speaking,
hmm
yes, we see people that have hemorrhagic events all the time in the hospital.
How about infection?
Oh, yes.
Right. Right. All those things that we were like listing that's, happens postpartum, that lands people either back in the hospital or prolongs their postpartum recovery or their stay. We were asking therapists and making such a strong case in this recent article to really look at the patient population as a whole, treat the impairments, essentially treat the impairments. And you'll find that care does not differ very much for those patients after birth as it would for any other person who's hospitalized. And so I think that we have, been pretty consistent in, writing and definitely making a case. But we just recently partnered now with therapists who are working with their systems to start gathering data to do larger scale studies, right? Because commentaries will only get you so far on a novel idea. I think that's why our topics were so popular. But now we're really, all of us are demanding for more research to support OT and PT services. And Jenna Rober was in one of our earlier courses when we were teaching the 15-hour ERAD course, and wrote this before we actually developed a perinatal health specialist certification program, which she also graduated from. But she texted me this, and I just want to read it. I received a hospital-wide award today, nominated by a couple of my coworkers. So grateful for your guidance with getting my program up and running. I'm so excited to continue advocating and helping others get into this area. And her story was really, really cool. She didn't start with all C-sections like we did. She actually started with a very, very smaller population that, she and a small team of therapists could get approval for, could see, and continue seeing other patients on their caseload as acute care therapists. And she did not have a pelvic health background, just like you. She was an
Mhm.
acute care therapist that only treated it really in that setting, yeah, especially at the time of taking this training, and then started to expand her access to OT services in her hospital. And I just think that this was really just phenomenal, that she was able to get recognized. And we've gotten quite a few messages now from acute care therapists who have gotten a pay bump, who have been placed as a team lead, who have really climbed the clinical ladder in their hospital, to get the recognition that they deserved as being experts in this area and starting something that just didn't exist. And what we started to realize along the course of training is that we were creating service lines in different hospitals. There is now over 84, and that's why I say the numbers are a little fuzzy because about seven came in just over the past 10 days, new hospitals that in our registry. So we're probably over the 90 mark. But that's where I say, we're constantly having to update that information because programs do rise and fall. Depends on who's, the team lead. If they have therapists that are either moving to different hospitals and maybe the program doesn't get the support and the momentum to keep going. So we have to constantly update that directory. But there is about 80 to 90 hospitals in the United States that are offering these services. Another therapist that we came across was acute care only, and now she's a mobile in-home virtual care physical therapist. And she was acute care. So again, no pelvic health background, and who now offers perinatal services. And so this is Dr. Caitlin Lamont, who wrote a testimonial after taking the certification program and just recently passing it. She said, when I signed up for the PHSC course through Pelvic Health Network, I did not know the value it would bring to me, both personally and professionally. I've taken many courses during my years as a physical therapist, but none have been as personal and professional as this course. I felt valued, cared about, encouraged, and supported in my mission to expand services to mothers before and after giving birth. And she has been very open and honest about sharing her own C-section journey online. And just even as a therapist, she stepped out of that and really embraced like what it was being a patient, Like we've heard so much from like moms who are not therapists, right? We talked about Pam's story. We talked about um Meg's story, that Ann Krogan treated. But this is a therapist who knew something more should be offered to me. I shouldn't have to think through this. I shouldn't have the privilege of being a physical therapist to know what to do. Something should be offered to me more than what's being offered to me after my major C-section. And I know I have to go home and care for my baby. She knew that there was something wrong. And I'm so glad that she found our training, which I'm hoping there's a lot more organizations out there who are offering this training. But we're really encouraging our counterparts out there saying, hey, this is an area of practice that we need more therapists to be, capable in serving this population. It's a huge population. And so, lastly, I want to end with a surgeon that you and I both know, Jenna.
Mhm.
Just a snippet of what she says about offering or consulting OT and PT in the hospital after birth, that I think just kind of puts the nail in the coffin for anyone who's getting pushback. Work with a surgeon like this. This is Dr. Karen Fox, someone I've now known since 2020, who had automatic orders for physical therapy after a cesarean hysterectomy, and then later on included those patients after complex C-section deliveries. But she knew even before I did as a physical therapist the benefits of offering rehab when those patients were still recovering in the hospital after major abdominal surgery, especially when they had a newborn to care for. So I'll let her talk, and please give me a signal to make sure that you can hear it.
My name is Karen Fox, and I'm a maternal fetal medicine specialist. We all know that we as doctors are getting a little bit more, I don't want to say burden, that's not the word, but we are trying to take care of more people with the same resources that we have. And there's also a real push both from a financial standpoint, from a patient satisfaction standpoint, from a infection control standpoint, to let people go home as soon as possible. We don't want to keep people in the hospital if they don't really need to be there, but we do want them healthy. And so by using our team members to the best of their ability, if I can have a physical therapist or an occupational therapist who's the expert in movement and doing those activities of daily living, meet with a patient one or two times, assess and give some recommendations, that frees up the nurse who otherwise might be the one who is trying to get the patient out of bed. If it reduces a fall because they're moving properly, that's time saved. It's an investment. And then that helps me as the doctor. Also, I spend a lot of time talking to my patients anyway, but if it frees me up to be in the OR and do that surgery and work to the best of my ability, then it just helps the team. And importantly, helps the patient and her family.
There's a story behind you and Dr. Fox. Do you remember?
Oh, I'll never forget. I think I know what you're talking about. Do you
Can
want
you
me to
just
share
share a
that?
little bit? Yeah, I do. It's so good.
Okay. So we both have worked directly with Dr. Karen Fox, at a previous hospital that we worked at. And I had a patient on the high risk pregnancy unit that had consulted PT to work with this patient. Now, this patient also had a past medical history of sickle cell anemia. And so one of the first things that we do in acute care is look at their lab values, do a full chart review, and her hemoglobin was in the fours. I believe it was a 4.6, if I remember correctly. So without even feeling like I needed to talk to anyone, I used my clinical judgment to say this patient is not, appropriate for skilled therapy at this time. And I knew that they were still awaiting a transfusion. So I was aware of all of that during my chart review. Well, I run into Dr. Fox, who asks me immediately if I'm going to work with that patient. And I, as politely as and professionally as possible, just let her know that I was not planning to. Her hemoglobin is at 4.6, and I know we're waiting for the transfusion. I think we'll get a bit more out of her after she's had that. And Dr. Fox did not like that answer and basically said, no, you need to work with this patient. She's still going to be getting up. She's going to be going to the bathroom. She's at a higher risk for DVT because of these low blood values that she has. So you need to work with her. And so she was in there with me. She stood in the room during the entire therapy session. And to be honest, I mean, of course it was a balance of, you know, a physician is watching my every move and hearing my every word to the patient. But then on the other side, I had the utmost respect for her because I think she knew that there was a risk associated with this. And I had made those risks and my own fears known. And so she was there also. I'm choosing to view it as like a safety net of I'm here if anything happens, you know, I don't want to say she'd take the fall for it, but in a way, she was showing her support. And so I'll never forget that being told, no, you are going to work with this patient, and I'm going to watch you. I'm going to be here the whole time. I will
Yeah.
never forget that.
I would say that you're accurate. I mean, I think that Dr. Fox has probably been our biggest cheerleader as a rehab profession.
Yeah,
For anyone that, I mean, just that doesn't know her, like if she, isn't in your hospital, if she's a physician at your hospital, she's going to stand up for OT and PT. Especially, I mean, if
and her
she's a
patients.
she's an
Yeah,
OBGYN, she's a maternal fetal medicine specialist. So yeah, she's going to advocate for her patients to get the best care possible, but then also for rehab therapists to have the support they need, right? To make sure that they're seeing this population. So she even without even me even realizing it was just saying all of that for us, right? When we were talking about like what's the difference between OT and PT on this population, Dr. Fox actually knows it better than some in our field. So like she actually like understands that OTs are doing those activities of daily living and PT is going to help my patient get up and walk and use
these
an assistive device.
experts.
I mean,
Yep, yep.
I'm like, okay, if she can get it, what's going on with us? Like,
Why is it so hard for us?
it's just so hard for us. So, I mean,
Yep.
I wanted to bring this full circle. Like, we get these questions, Jenna, like emails and LinkedIn messages, Facebook messages, 30, 40 questions. I just can't believe like we did not have time to answer 30 to 40 questions after
Right.
we presented for MedBridge and APT acute care each.
Well, I think
Um,
NetBridge, there were about 80 questions that we didn't get to,
you
but
are right.
yeah, it
You're
was.
right. Yes. So I wanted to just at least give the bare bones. Like this is enhanced recovery after delivery. This is why we're training therapists to really expand access to their services within the first 7 days, wherever that person is. If they're still in the hospital, this is what you can do. If they're on the high risk pregnancy unit, hopefully you'll have a physician like Dr. Fox who will, have your back. Especially if that person's in a critical condition of 4.6 hemoglobin. Come on.
Yeah.
Like I didn't want to see her at 5.4 and I didn't have a choice. You just don't say no to Dr. Fox, but you did. You said
I
no.
tried. I tried.
What I mean, you've said no. You just it had to be a
Couldn't
yes.
follow through with it.
Couldn't,
Yeah.
yeah.
Mhm.
And then, I mean, just things like that is that first 7 days, if they're at home, if they're, being seen, like Ann Krogan was seeing that patient, able to intervene, we just want therapists to be able to expand access to rehab for this population. We just think there's too much data that shows we're not doing enough. 80% of the maternal mortality rate of maternal deaths, we know the majority of those are happening after birth, not while that person is pregnant. And then the majority of those deaths are happening in the first 6 weeks, while the rest of our field is waiting, unfortunately, 6 weeks to see that patient that might not show up. And so we wanted to really prepare you know, this team of therapists, if you will, in every hospital where patients deliver, to have someone who can go into the maternity unit and feel like, yes, I can absolutely, intervene. So if there are any questions at all, any questions from those of you who, joined us, wanted to just listen in to that big overview, feel like there's so many questions that we answered and just going through that in just more detail than we've probably ever have before. Please ask away. Ask in the chat, on mic, anything. Feel free to just join in and ask. But Jenna, is there anything that you want to share specifically about even your background that just makes this a compelling case for someone who's not a women's health therapist like I am, who had to go into the hospital and learn acute care and then learn in-home care and then now combine my knowledge with virtual care, which I'm providing now. But you are an acute care neurotherapist. Like, what's your story?
Yes, that is correct. So, um, so what really, there were a few moments, but one that stands out the most to me that really drove me into working with this population and really trying to make strides in initiating and implementing these programs is so as you mentioned, my background is acute care, neuro. So I worked on neuro floors, trauma. I work in the critical care, so neurotrauma ICU. And there was a patient who was admitted back to the hospital who had severe brain bleeding that required burr hole surgery to relieve some of the intracranial pressure. She was in the ICU for quite some time before eventually transitioning to the neuro floor and had significant dense left-sided hemiplegia, had to relearn how to talk, all of this. And when digging through the chart review, I looked at it and the reason for the admission was severe hypertension related to preeclampsia. So it had gone from preeclampsia to what we now call eclampsia. So eclampsia meaning a neurologic event. So she had had the neurologic event, which was a massive brain bleed. And when I looked at it, she had just given birth 3 days prior. She had had a cesarean section. She had discharged only 12 hours prior to her then readmission for that preeclampsia that led to the eclampsia. So I immediately was thinking, wait a second, is there anything we could have done during those 3 days when she was admitted postpartum? Could we have caught some of those signs of maybe her blood pressure starting to rise and starting to become too elevated before she ever left the hospital? Now, for those that don't work with this population, you may not know that nursing takes vitals. They do it fairly often, actually. I think they have to do it every 2 or 4, something like that, hours. And they're doing it at rest. That is it. The patient will always be in a semi-reclined position. They will be in the bed when they do this. They are never assessing vitals during activity. Now, this woman was also a mother of 3, so this was now her third child. So what do you think happened when she got home and now had a newborn, but also had 2 other children? within those 12 hours, she's now having to do a lot more activity than what was being asked of her in the hospital. So I was thinking to myself, not only could we be assessing vitals, but we could be simulating the home environment to really get a good picture of how are their vitals responding to the demands they will need to do. Now, I did want to, we have something in the chat here, so I do want to make sure we address any of these questions that are coming in. Um, we have many moms needing a walker for discharge home. We are trying to find better education or wording for moms needing a walker and also having to care for their child,
Hmm.
often without anyone else in the home that can help them.
Oh
What
man.
are interventions and education you are providing for these patients?
A rolling bassinet. A rolling bassinet. And I mean, that's so hard, right? Because how about carpeted environments,
Sure.
right? It's so hard to simulate that. We could simulate that in the hospital over, wooden floors or something like that, or just hospital floors. But if it's a carpeted home, how well will a rolling bassinet work? But we had to do this for a mom, unfortunately, who could not walk postpartum. Oh, and her case was so sad, but she could not walk and she was not discharged home with a walker. I mean, Jenna was terrible. When I got involved, and that was virtually, she had been urinating and defecating in a bowl
Mm,
from her couch because she could not physically get from her couch where her family was at least able to get her from the car to her couch. That was a awful ordeal. But then she couldn't get to just the bathroom in her home. And so I was just like, never again. Like she was able to finally, get a rolling bassinet to at least hold on to that. I mean, which is right. That's not safe. That's not a weight bearing, you know, um, uh, thing. But in the hospital, they have these handles where moms could at least use it. And so just at least with those situations where moms will be home alone, as in her case, if there's any way to advocate that her family really support her with something that she can at least care for her baby in and use to at least give her the upper body support that she needs, that would be my go-to. Because right, like if they're caring for their baby or they want to at least, bring their baby from one place to another and they're using a walker, I mean, that's just it's not going to be feasible, right? There's no walkers that really exist that allow for you to position a baby on some type of, whatever it is and attach it to the walker. We just don't have anything like that. So it's really the rolling bassinet, which I mean, talk about privilege, right? How are you going to get one? I mean, so that's the thing. I mean, I think that the bigger conversation is should this person be discharged home alone
hmm
with caring for a baby, or should we be looking at inpatient rehab services, which again would separate her from her child because of admission criteria and babies, not being able to be with their mom. So there is no easy answer. I feel for the therapist who's navigating these challenging situations. There is no easy answer. But I think that's where we're really where that advocacy comes for probably a longer hospital stay, which hospitals don't want to pay for, right? Because they're giving so much, for that patient's visit, especially if it's a vaginal cesarean birth, and then they have to cover the complications. Um, so yeah, no easy answer. But yeah, it's gonna have to come from privilege. It's gonna have to come from support. It's gonna have to come from, a lot of resources put together to give that person what they need. That's
And
such a good
don't
question. My
it
gosh.
is, it's a great question. And I would also say, I really recommend reaching out to the case manager or social work that may be involved in the case to identify what additional resources may be out there. There are a lot of churches and other organizations that give things for free. They donate, they do free rentals, like they'll do a rental service for however long that person may need it. And it looks like we have a response to that saying that one therapist had suggested using a stroller within the home, which is essentially a rolling bassinet. So as long as the carrier, the way for the baby to be with the parent as they're rolling it, I think that that would suffice.
Yeah, especially if it's a stroller that where you can still see sometimes they accommodate where the baby can be either turned towards you or something. And hopefully where not enough force, causes the stroller to lift, obviously. That unfortunately happened to my niece where she was discharged home without anything and she nearly pulled down the baby's carrier because she was trying to find something to mobilize off the couch where she didn't even get to a bed. She was sleeping on a couch after her unexpected C-section. And I remember my nephew like calling me and saying, baby almost toppled over because, she was trying to get up and using the carrier or the bassinet as a weight-bearing surface. So I mean those are scary. Even to have that in my family. But I see another question. Great question.
Yes.
That is tough. But social work, case management, yeah, I'm right there with you.
So this other question is asking if we see any prenatal or postpartum patients with FND. That sounds like they've had an increase in FND in this patient population specifically. They struggle with getting them to inpatient rehab when our young moms want to go home for the remainder of their pregnancy or to stay hospitalized until delivery. We get a big push from the team to get them discharged ASAP. We also struggle since the team and psych really don't want to put that as a formal diagnosis in their charts. Ooh,
Wow.
wow. So how are you knowing that's what they have if they're not giving a formal diagnosis? I guess would just kind of be a follow-up question that I have. But I would say so. Working with someone who has FND is
Can,
going to
and can you
be
just say that for just our listeners afterwards, yeah.
so. Well, I guess I should make sure that this is what the person is referring to, but functional neurological disorder. Is that I guess I would love to make sure that we're talking about the same thing. Okay, yes.
Okay.
So, um, whether it's this patient population or any other patient population, that kind of the same concepts apply. So we would obviously be advocating for whatever is safest for them. If we have not seen that they can do things independently or that they are able to care for themselves, mobilize, transfer, then we really can't recommend home. At least I would not personally, because they're not only having to transfer themselves, they're now having to also transfer a newborn within, if we're talking about this population. But when you're working with this patient population, a lot of times best practice is to not really emphasize or talk about the deficits you're seeing, but to emphasize what they are able to do and give a lot of that positive feedback and give a lot of the encouragement in that way. Because oftentimes what we see is if we mention the deficits that they're showing or saying, oh, you're not picking your foot up enough or you're not doing blah, 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 then we tend to see an exacerbation of those deficits. It's almost like they start to go down this rabbit hole and they start spiraling downwards. But if they had a good step, then you could say, oh, that was a great step. Your foot cleared the ground that time. Then it helps psychologically for them to start doing that more often. So it again depends on what their specific deficits are. But I have worked with some that had foot drop, but they didn't truly have foot drop. It was FND. I'm not sure if that really answers your question. It's a really tough question. All we can do is continue to advocate, and if the healthcare team decides to do something different, it unfortunately can be out of our control. And if the patient decides to do something different, they always have that right to.
Yeah. You probably are familiar with this, but I co-treated with an OT with a person with FND. And I mean, she was on day 6 and the OBG, I mean, they were really pushing us to like recommend home for discharge. She had a flight of stairs. She lived on the second apartment, but like, yeah, I mean, psych didn't really want to put that in her chart. But yeah, I mean, she was just not walking and it required just a lot of just creative, like I would watch the OT and she would just do timed activity and standing and try to do as much as like baby care to get her like used to changing diapers and things like that and not just depending on nursing to do it. And just, I mean, just really encouragement. Were eventually able to do stair negotiation, but it was, I mean, at one point it was like she wasn't responding to sensation testing, motor testing, nothing.
Mm.
I mean, it was just like, what is this? But yeah, no, that's totally valid. And I see that her this therapist follow-up, they are often coming in after a fall or sudden onset of hemiplegia, automatic muscle contraction, but flaccid when trying to move. Yeah, medical workup does not find anything significant. Sometimes walking with what platform? Rolling walkers?
I think so. Mm.
Yeah. Um, yeah.
There's usually a
So usually
history.
there's also a history of psych diagnoses that's again tough, and you can't get them into inpatient rehab. Like they're refusing.
Right. Or if there's no formal diagnosis, inpatient
Right.
rehab won't take them either. But again, it comes down to you still can't necessarily recommend home unless you're recommending home with 24/7 supervision, with the ability to have assist. Here is my full long list of equipment that they would need in order to safely discharge home. That's really all we can do
Right.
at that point is just give our true clinical judgment. Now, I didn't want to skip over. We had someone else who mentioned that they have been piloting seeing these patients on the maternity unit.
Nice.
Yay, that's amazing. But it sounds like maybe you're having difficulty building support from, I think, maybe other PTs. I'm thinking that's what you're trying to say in your message to expand your ability to see these patients, and then any suggestions on building a bench within therapy services. So, yeah, sometimes we are our own fellow um, therapists, right, can be those that prevent programs from flourishing. And a lot of times we get others that say, "Oh, it's our manager," or it's the OB team that's unresponsive. Um, or we just don't have the staffing to do it. But then we have this where the therapists truly aren't interested or don't want to do it, but the program's taking off, right? And it sounds like maybe that's your situation. So one of the things that I have done that, and I'm happy to hear any ideas Rebecca has as well. But one thing I did that did generate a lot of interest within my own rehab team was I gave an in-service, but my in-service was about abdominal surgery because in acute care, OT, PT, we're working with people after other types of abdominal surgeries all the time. They could have an emergency laparotomy because they were in a car accident and they have, multiple organs that are bleeding. So they have to have an emergency laparotomy to potentially repair any of those organs. They could have a gallbladder removal, a colectomy. There's all these different types that we see all the time. So I titled it that and got a huge turnout of therapists because of course they want to do best practice and they work with these patients, but I conveniently added in the cesarean section population as well and provided evidence, of course, about how this also is a major abdominal surgery, and provided some of the literature out there that also supports the benefits of PT and what we can do. And if we're doing it with other types of abdominal surgeries, why are we not also doing it with this patient population? So after that presentation, I had like at least 5 OTs come up to me. I had multiple PTs saying that they were really interested, which was great. We now had a team and it wasn't just on me anymore. So maybe that will help you.
I think I actually used that presentation. Yeah, and like changed it. No, it was so crazy
Oh
because I
yeah,
was
I
just
think you
like, this
did.
is so good. Like this is so good. And it's kind of like, yeah, it's just like not a gotcha, right? But I mean,
Right.
we're
No,
talking about
no, of
abdominal
course not.
surgery, and so we really just used that to drive home the point that we knew it would be a harder sell if we were talking about vaginal delivery.
Right.
two-thirds of birth are vaginal delivery. So, I mean, we could have made a big case on that. But because of acute care therapists being so overburdened, overwhelmed, they already have so many priorities on other units. How could we sell? And it was really that presentation. I used it, modified it, and used it in another hospital system just to say, in these circumstances, let's at least be ready as a team to see these rare circumstances where after a C-section or after a lot of blood is lost, we can do an assessment. And here's even an outcome measure. And you and I developed this outcome measure, not validated, nothing. We're trying to actually teach doulas how to use it and just patients themselves. But we at least have something that looks really close to the impact, but it takes into account those OT activities of occupational activities of daily living as well that patient is doing that combines kind of the OT and basic mobility impact. For those of you who are acute care therapists, that's an outcome tool that's used in the hospital. And so that's really what we did is that we just taught them what to look for. And when you explain that to an acute care therapist, I mean, to me, it's like, oh, I mean, I see anything that walks through the door in the hospital. This makes sense. And so, yeah, I definitely took that from you. Uh, I mean, that was just brilliant. And I remember like watching you do that presentation. I'm like, this is brilliant.
Well, thank you. I will say I've had therapists that I've worked with that, they'll say, "Oh, I don't want that. I'm not interested in pelvic health," or which of course I don't do that either. And I don't want to say there's nothing pelvic health related, because of course there is. Pelvic health is actually in just about everything we do. Because are you holding your bladder in your bowels? Then great. But that's beyond the point of this. But we're not doing any type of internal exam. We're really not even doing an external exam. We're doing nothing related to that. It is coming back to basic functional mobility, their activity tolerance, vital signs during activity, checking if they had a C-section or if they had a perineal laceration. What does the incision look like? Does it look like it's healing properly? Do they know the steps and things that they need to do to prevent a wound infection down the road, or what an infection looks like and when they need to call their physician to let them know so that they can get back in and see them. So these are all the things that I really believe that therapists just have the knowledge and skills, and it doesn't necessarily require a pelvic health background by any means. But I do think that to really get your foot in the door and to really help a program to succeed, this program can be really helpful because it's tailored specifically to this population, both high risk, immediate postpartum, and it's all postpartum. So we go into specific diagnoses as well.
Awesome. And so the program is Enhanced Recovery After Delivery. It's a training, 15-hour training that has an option of advancing to a 30-hour certification program, sitting for an exam and getting a certification as a perinatal health specialist. And that's really emphasizing your expertise for working with the high-risk pregnancy population as a rehab therapist, or immediate postpartum within the first 42 days. We emphasized a lot today about the first 7 days, but that really helps you to fill the gap as a clinician. And we have over 42 specialists that we have seen, come out of this program, building services that we never even really imagined in virtual care, home health, mobile therapy, and of course in the hospital. And so we would love really for you to just keep getting more of the information that's already out there that we do for organizations. MedBridge has a course that now is accessible to acute care therapists. I think when we first offered it, and they told us that over 1,200 had enrolled or something like that,
Mhm.
that we're going to be there live. And Jenna, you're right, we didn't get to 90 questions. And so we were hoping to really give more insight through this presentation today. But then we also did a talk with acute care APTA that's free. And so we put that out there on YouTube and on their platform. And so we're really just we're doing these monthly events, monthly Q&As, monthly talks. We do a lot of webinars for other organizations. But if you are really hoping to get more training and just like, get the whole like, front to start, how do you grow this program? How do you start a new service line? How do you start to climb the clinical ladder as a team lead? How do you build a team? That's where you'll spend time with us. And so we offer that in person, via self-paced. We have had hospitals sign their therapists up as teams to take this program self-paced. A lot of options. So look for Enhanced Recovery After Delivery. You can go on our website, enhancedrecoveryafterdelivery.com, and it'll give you a lot of information, but we're always just available. I mean, it's very easy to find both of us on LinkedIn, Facebook, just asking questions. We have a Facebook group called Enhanced Recovery After Delivery, and there's questions always in there. There's another one by Ann Krogan, a therapist that we just presented on, called the OBOTPT or OBPTOT Facebook group for those therapists that are interested in offering services to the obstetrics population. So plenty of resources out there, but yeah, just keep us posted on what you're doing. These questions were fantastic. Um, and hopefully we will see you soon and just stay connected. Thank you so much for your time tonight. Thank you, Jenna.
Everyone. Yeah, thanks.